Assalamu alaikum. I welcome you all to the next session, which is session 8, plasma cell disorders. My name is Dr. Syed Waqas, Imam Bokhari. I'm a consultant hematologist at Shaukat Memorial Cancer Hospital. We have two talks by a couple of leading experts in plasma cell disorders from the US. But before that, I'd like to introduce all the expert panelists. So, chairing this session is Dr. Zeba Aziz. She's a consultant hemato-oncologist. We all know, currently based at Hameed Latif Hospital, Lahore. Uh, we have Dr. Aisha Jamal. She's a consultant hematologist at NIBD Karachi. Dr. Muhammad Ayaz Mir. He's the BMT chief and consultant hematologist at Shifa International Hospital. Dr. Kamran Mahmood, consultant hematologist at PATHWEL, Rawalpindi. And Dr. Saima Humayun. She's a consultant hematologist at AFBMTC, Rawalpindi. So I would like to invite the panelists to take the seats, and we'll get started with the session. Thank you. So our first talk is by Dr. Faiz Anwer. He is a consultant hematologist and oncologist at Tosig Cancer Center, Cleveland Clinic, and his expertise is in plasma cell disorders and stem cell transplantation. So over to Dr. Faiz Anwer for the first talk on how I sequence treatment in AL amyloidosis in 2024.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. It's a real pleasure to present on amyloidosis in this meeting. My name is Faiz Anwer. I'm a staff physician at the Tosig Cancer Center, Cleveland Clinic, Ohio. The goal from my current talk are I want to highlight the delay in diagnosis issue in patients with AL amyloidosis, and we'll talk about updates in the treatment of amyloidosis. So in my opinion, the major issue in amyloidosis is a significant delay in diagnosis. Patients have multiple organ involvement at the time of their presentation, and they have symptoms based on their organ involvement. That leads to variable symptoms, confuses the providers, and delay in the diagnosis is commonly seen. There is literature out there which shows that 2 to 4 year delay in the diagnosis of amyloidosis from the time patients start experiencing some symptoms. And what happens if there is a delay in diagnosis? Patients suffer from progressive organ failure, irreversible organ failure can happen, and if they present with advanced heart failure or advanced kidney failure and dialysis, they have poor quality of life, and unfortunately, risk of death is high in patients with advanced disease. 37% of the patients get diagnosed more than a year after their initial symptom. A third of the patients are seen by more than 5 physicians before they are diagnosed. And only 8% of the patients see one physician before the diagnosis is made. So it's very important to diagnose these patients early and start the treatment early to stop the abnormal fibril secretion, which leads to further organ dysfunction. At the bottom of the slide, I am showing a Mayo 2004 staging system of survival probability. If you pay attention to the stage 3, almost half of the patients in the stage 3, unfortunately, died within a year of their diagnosis. If we look at the Mayo 2012 and Mayo modified staging system with the stage 3B patients, they unfortunately are dying within 6 months of their diagnosis with amyloidosis if they have advanced cardiac involvement. So now I want to highlight this issue with the 2 case examples. In the first case, this is a story of a 55-year-old Caucasian female. She was diagnosed in 2020. She presented to the primary care physician initially with some symptoms and no clear diagnosis was made. Unfortunately, her symptom worsened. She was admitted in the hospital, and over 1 year, she had 11 hospital admissions. She was diagnosed with atrial fibrillation with RVR. She was diagnosed with advanced heart failure. She was seen by multiple physicians in that year, including two cardiologists and her primary care physician, who has seen her multiple times. But the correct diagnosis was not made. Ultimately, she was diagnosed with stage 4 cardiac amyloidosis. It was cardiac biopsy proven. And along the course of her journey and treatments, she had actually a liver biopsy, which showed liver involvement with amyloidosis. Lung biopsy, duodenal and colon biopsy were done at different times, and each time an organ was biopsied, she had proof of amyloidosis in those organs. At the time of diagnosis, she was advanced cardiac failure. ProBNP was more than 7,700. FISH testing showed trisomy 9, 15, and gain of 1Q. Fortunately, this patient is doing great. The second story I want to share is about an engineer. He's 62-year-old by the time he gets diagnosed. 9 years before his diagnosis, he started with hand symptoms, with hand tingling, numbness, which started initially in 2015, 2016. Initially had left hand involvement, later on had right hand involvement, ultimately gets diagnosed with bilateral carpal tunnel, undergoes corrective surgery in 2018. Well, in the next 2 to 3 years, his symptoms come back. He undergoes a second surgery with the second surgeon, thinking that the first surgeon did not do a good job, but his symptoms come back within a year or 2 years of the second surgery. 18 months before his diagnosis was made, he started noticing bilateral ankle edema, and it was felt that maybe he's on a calcium channel blocker for a low blood pressure, for blood pressure control, mild hypertension, and that may be contributing to the symptoms. 5 months before his diagnosis was made, he passed out at home for 10 minutes. He was taken to the emergency room by EMT. He was evaluated, and they felt that maybe he has no other symptoms. Maybe he was dehydrated. Maybe there was a hot weather in Cleveland. Maybe he had too many beers the night before, and he went home. 4 months before his diagnosis, he was actually visiting his mother in the hospital, and while sitting in the room, he noticed that the room started getting dark from ground up. He passed out. He was found stiff in his chair with eyes open. He woke up foggy after a few minutes. Conveniently, he was already in the hospital, so they took him to emergency room and gets admitted there. And during this observation admission in the hospital, they noticed that he has a wide complex tachycardia. And that further leads to testing and ultimately gets diagnosed with IgG kappa AL amyloidosis with cardiac involvement. At the same time, his kappa lambda ratio was high, and that meets the criteria for even multiple myeloma. And the bone marrow showed 30% clonal plasma cells. His cardiac biopsy was done, and it shows proof of kappa light chain amyloidosis. At presentation, he had elevated creatinine. He also had 4-gram proteinuria with predominant proteinuria in the M protein. So this is just an example of a case where I feel that there was a 9-year delay from initial symptom to diagnosis. We actually published this case in the Cleveland Clinic Journal under a section called Symptoms to Diagnosis, just to highlight the issue of delay in diagnosis in such cases. So treatment landscape for amyloidosis has changed and led to significant improvement in the last 2 decades, starting from melphalan-prednisone in the 90s, and using dexamethasone, and then using bortezomib dexamethasone. Later on, we started using bortezomib, cyclophosphamide, and dexamethasone. And the current standard of care is a combination of 4 drugs with the daratumumab, cyclophosphamide, bortezomib, and dexamethasone. Only a quarter of the patients at diagnosis, if they're evaluated for transplant, they're eligible for transplant. And the current standard of care is aimed at suppression of the light chains, the fibril production, to stop that ongoing damage to the organs. The future trials are looking at how to improve on that. And we are now looking at better suppression as well as removal of the amyloid, which is already present in the heart. And we have two agents which are more advanced in the drug development. One is the ensilamimab, KL101, the other is bertamimab, which are being tested now in the phase 3 trials. In the same space, CAR-T and bispecific antibodies are being used to improve the better suppression part as well. So this is the clinical trial, Andromeda trial, which was published in NEJM in 2021 that led to the establishment of the current standard of care. I highlighted Dr. Valent's name from our center. So this clinical trial was performed in patients who were newly diagnosed with AL amyloidosis, and they were given data with Cyber-D compared to Cyber-D alone. And the 4-drug combination showed higher frequencies of hematological complete response, which was about 53% compared to 18% in the intervention group versus the observation group. The improvement from major organ deterioration or hematological progression was also better in patients with 4 drugs. So the clinical trials endpoint were hematologic complete response. The secondary endpoint includes survival free from major organ deterioration or hematological progression, organ responses, overall survival, hematological complete responses at 6 months, hematologic very good partial responses are better, time and duration of heme complete responses, time to next treatment, and reduction in symptoms such as fatigue. And based on the trial, the intervention group with the 4-drug actually had superior outcomes in all these categories. Here is a summary of the responses in the daratumumab group compared to the control group and shows significant improvement in the outcomes. Now I want to highlight this case, which is an example of what happens if you diagnose somebody on time and treat them timely. So this patient I saw back in November of 2018. He's a late 40s male, an attorney by profession who goes to his PCP for regular checkup. A routine lab shows he has low serum albumin of around 2 and a high proteins in the urine. And further testing revealed that he has a diagnosis of Mayo 2012 stage 1 disease. Kidney biopsy was positive for amyloidosis. Now this was November of 2018. Back then the standard of care was Cyber-D. We had the Andromeda trial open, so we offered him, and luckily he was randomized to the 4-drug arm. And after 6 months of therapy, achieved very good partial response. He also achieved an organ response with proteinuria improvement by 53%. But he was so young, and we had a chat after 6 months, and because he did not achieve complete remission, we offered him a transplant, and he actually underwent MEL200 transplant with an autologous rescue in April of 2019 and achieved a complete hematological remission. And I met with him this year back in May of 2024. His proteinuria is now down to 0.08 grams. He presented with a peak proteinuria of close to 10 grams per 24 hours. His serum albumin has improved from 2 to now 4.7 milligram per deciliter. So on the right side, I'm showing the 5-year follow-up. The top graph shows the proteinuria peaked around 10 and now improvement. And on the right side, on the bottom, we show the serum albumin at presentation, and with the therapy improvement in the serum albumin to now in the normal range for many years. So how do we treat patients who present and have advanced cardiac involvement? At our center, we use Cyber-D on days 1, 8, 15. We actually skip the day 21, and we give the cycle every 28 days. Dara is given weekly for 9 dosages, then every other week for 4 months, and then every 4 weeks for up to 2 years. Cyclophosphamide dose is given up to 500 milligram weekly, and for bigger patients, we cap at 600 milligram for PSA of 2.5. After third dose of DARA, we consider elimination of all pre-medication, including steroids and other pre-meds except Tylenol, acetaminophen. We also consider dose reduction for bortezomib, starting at a 0.7 to 1 milligram per meter squared in high-risk cardiac patients. We may escalate to standard dose bortezomib in the absence of cardiac arrhythmias. We consider 12 milligrams of dexamethasone as pre-medication for first 3 doses of high-risk cardiac patients. We also consider elimination of steroid after 3 doses of daratumumab in high-risk cardiac patients. And this is because of fluid retention, cardiac symptoms get worse with higher dose of steroids, and many of these patients may have other medical comorbidities. Now I want to present a case of this relatively young female. She was 61-year-old when I saw her. She was unwell for the last 4 years. She started with the symptoms of bilateral carpal tunnel. For some time, she was noticing and complaining of tongue enlargement. She also had some vague joint pain and joint swelling complaints that she was getting treatment for that, and also noticed voice changes. Ultimately, with workup, she's diagnosed with IgG kappa, a predominant kappa light chain, multiple myeloma with kappa light chain of more than 500. Her bone marrow shows 80% plasma cells, standard risk. But bone marrow biopsy also showed significant amyloid deposition in the bone marrow. Her cardiac or renal testing was negative, but she had sensory neuropathy and a tongue enlargement. So based on that, though we did not do a tongue biopsy, but based on all this picture, I feel that she has a dual diagnosis. She meets the criteria for multiple myeloma as well as she has a diagnosis of AL amyloidosis. So we actually treated her on the lines of multiple myeloma with the DARA VRD because she had no cardiac involvement. Now, if she had cardiac involvement, we would have favored use of DARA, SABD, or a DARA VCD-based therapy based on the lines of Andromeda trial. Now, if we compare the outcomes of the Andromeda trial with the Perseus trial, the complete responses with the Andromeda trial are only up to 53%. As compared to Perseus trial, the complete responses are better, are approaching almost 88, 89%. So based on that, if you have a patient who has a dual diagnosis and can be treated based on the Perseus trial, we will favor treatment with the Perseus trial because of the superior outcomes of underlying disease. I just want to remind that the response assessment in amyloidosis is slightly different from response assessment, which is done in the patients with multiple myeloma. A complete response in amyloidosis means normal free light chain ratio, normal free light chain levels, and a negative immunofixation. VGPR will be difference with the free light chain involved and uninvolved. Difference will be less than 40 milligram per deciliter. And a partial response will be more than 50% reduction in the free light chain difference. This is our internal schema that how we manage newly diagnosed patients with amyloidosis. If these patients are given daratumumab and achieve VGPR, we look for reasons not to do a transplant. We will continue to do daratumumab and finish 2 years of therapy. For patients who are relatively young, for patients who have no cardiac or low cardiac involvement, or may have only kidney involvement, they are the ones who are considered for transplant. There are some patients who can be considered for kidney transplant if we control their underlying clone bearer. So those are some rare indications where we will prefer doing transplant, autologous transplant for these patients. And patients who have dual diagnosis of AL amyloidosis and myeloma, if they don't have significant cardiac involvement, we may favor doing autologous transplant in that setting. So who are the patients who are an ideal candidate for autologous transplant for a better disease control and a longer disease remission? These are relatively younger patients with low cardiac involvement or no cardiac involvement. If they have advanced cardiac involvement, their risk of mortality is more than 10%, and those patients should not be offered high-dose therapy. Patients who achieve a hematologic VGPR or better, we will continue conventional therapy, daratumumab, and may not offer autologous transplant to those patients. In the setting of a partial response, we consider giving 1 to 2 additional cycles of a salvage therapy and see if these patients are eligible for transplant, and we'll do transplant for them. Patients who have progressive disease or at best stable disease, we proceed to second-line therapy after first 2 to 3 cycles of treatment. So this is kind of an internal criteria which we use for autologous transplant eligibility. Patients who are physiologically younger age, less than 70, have better performance status, has minimal symptoms of heart failure, have stage 1 or stage 2 disease. They have systolic blood pressure more than 90. Their NT-proBNP is less than 5,000 or preferably less than 1,800. And they have creatinine clearance of more than 30. These are the patients who we may offer transplant. Now, I want to highlight a case who was diagnosed back in 2019. This is a patient who was 71 at the time of diagnosis. He was diagnosed with AL amyloidosis with a lambda light chain at time of diagnosis. He had 1114 translocation in addition to 1Q gate. He was diagnosed with Mayo stage 2, but this is one of those patients who has really significant amyloid involvement in the body. He had heart failure symptoms and tachyarrhythmias. He had GI bleeding secondary to amyloidosis. He had recurrent pleural effusions requiring Plurex catheter for many months, and pleural biopsy was positive for amyloidosis. He underwent frontline therapy with the Cyberdi, and remember this was still in 2019, so data was not part of the standard of care at that time. And we got stable disease at best. He had only 40% reduction in the light chains difference. And the second line therapy was addition of the daratumumab, remove the cyclophosphamide. We combined data with bortezomib and low-dose dexamethasone. And with that, he achieved good disease control. He was off therapy for some time. And third line therapy was on a phase 2 clinical trial with ensalutamide and the daratumumab. He achieved good disease response and was actually able to go off therapy for 15 months and then have now a slow biochemical relapse. And considering he had 1114 translocation, he's now on standard of care daratumumab and off-label venetoclax for the treatment of amyloidosis. Now, what is unique about this translocation 1114, half of the patients with the AL amyloidosis are positive for 1114 translocation. Plasma cells with 1114 have a higher expression of BCL2 and a lower expression of MCL1. 1114 has emerged as the first predictive marker indicating susceptibility to BCL2 inhibition. Venetoclax inhibits the BCL2, and that stops this anti-apoptotic protein and leads to the cell death in the amyloidosis as well as in the myeloma cases. Now, how do we treat patients who have relapsed amyloidosis? On the left, I'm showing a recent table from the recent NCCN guidelines, and it is showing a lot of drugs which we use in the space of multiple myeloma on the right side. I want to say that how we think about treatment of relapse amyloidosis. If patients have been exposed to data, but there was a significant gap with the last exposure, then these patients can be retreated with a data-based regimen. Some patients may be still data naive, and so data is preferred in that setting. If patient has 1114 translocation, then venetoclax can be used, and we start with a lower dose, but somewhere between 200 to 800 milligrams per day can be given in combination with a PI, preferably bortezomib. Can be also combined with other agents such as immunomodulatory drugs as well as proteasome inhibitors and daratumumab. We need to be mindful of venetoclax-based drug-drug interactions. IMiDs leads to fluid retention and a worsening of heart failure symptoms. So that's the reason we don't use these IMiDs for the diagnosis for newly diagnosed cases. Similarly, carfilzomib has a signals of cardiac symptoms and arrhythmias and concern about sudden cardiac death with arrhythmias. But in a relapse setting, if patients have no active arrhythmia, these drugs can be tried carefully in a lower dose. This slide summarizes the drugs which we are using in the patients with the multiple myeloma, and all these drugs can be used with proper combination and adjustment in the treatment of amyloidosis in relapse setting. So the innovations are now moving with a focus change from amyloid fibril suppression to better suppression and removal for the treatment of AL amyloidosis. The left bottom, I show a picture side by side of a normal heart and a heart of a patient who had cardiac amyloidosis. In the middle, I am showing an echocardiogram image of a normal heart. On the right side, I'm showing an image of an echocardiogram of a patient with advanced cardiac amyloidosis and septal thickness. So when you have this much organ dysfunction because of amyloid deposition, we now need to focus on removal of that amyloid, and that will improve these patients' symptoms quickly. So in that space, the CARE 101 has the more advanced data, starting from the phase 1 and now multiple presentations going back to ASH 2021, 2022, and 2023. We have contributed to the phase 2 data, and initial signals look really good. And based on that initial signal, we have now completed enrollment into phase 2 multi-institute phase 3 trials. And the trial results are eagerly awaited at this time. And we are hoping that ASH 2024 update is expected soon. Bictamimab is the other drug which focus on the removal, and going back to the initial phase 1, phase 2 data and the phase 2b Toronto data, and later on the VIII study which showed a subgroup benefit in Mayo stage 4 patients. Now the phase 3 AFFIRM AL trial is ongoing because this trial is only focusing on the Mayo stage 4 patients, so there is difficulty enrolling to this trial, but this trial is exploring the benefit of bictamimab for advanced cardiac patients. I have tried to scan the recent updates, and there are multiple ways the care for amyloidosis is improving. SWAG is studying in a prospective phase 3 study the use of daratumumab followed by autologous transplant versus dara-CyBorD consolidation and a dara maintenance in patients with the newly diagnosed AL amyloidosis patients. And this study will help us understand the true benefit of lack of benefit of transplant in a prospective setting. Now, monitoring of the systemic light chain using mass spectrometry in the serum is being tested. MRD is being tested in patients with systemic amyloidosis and how to use the MRD information for managing these patients in the space. Teclistamab is tested. ADC belantamab vedotin in relapse setting for amyloidosis is being investigated. And then BCL2 inhibitors are also being tested in patients in the relapse setting. This slide summarizes some of the recent papers we have contributed to. We have a small series of patients who had relapsed myeloma as well as a dual diagnosis of amyloidosis who underwent CAR T therapy. So we shared our experience of safety and efficacy of the CAR T in this space. We also shared our experience of localized light chain amyloidosis. It was a large cohort with 12 years of follow-up in this set of patients who were diagnosed with localized light chain amyloidosis. So we're coming to the end of this presentation. Dara-CyBorD is the current standard of care, but it's only achieving 50% complete responses, which need to improve. Newer immunotherapy, including CAR-T and bispecific antibodies, will be tested in newly diagnosed as well as in the relapsed, and likely will improve outcomes. Antifibril antibodies will show an improvement in the end organ function and will improve in outcomes of these patients. Autologous transplant will retain a role for carefully selected patients. The benefit is progression-free survival more than a decade, but we want to keep the mortality rate less than 5%, preferably not more than 2 to 3%. And supportive strategies are very important. We really need to look at reduce the infection risk, reduce the drug toxicities, and we should be proactively doing dose modification for these patients. Here is a story of a patient who is a young male, is a musician. He started noticing almost a year and a half before he was diagnosed, leg weakness and numbness. By the time he was diagnosed, he's unable to walk, unable to function. He cannot use keyboard. He cannot hold the drumsticks to play his music. And ultimately, on a pseudo nerve biopsy, get diagnosed with a lambda light chain amyloidosis. And in this picture, I'm trying to show the thenar and hypothenar and the muscle loss of his hands. So it's very important to recognize that work we do is important and has real impact of lives. So thank you for your excellence in service. The issue is that I do not make the diagnosis of amyloidosis. The diagnosis is made by primary care, cardiology, nephrology, neurology, and surgeons who initially see these patients for different symptoms, and then they refer these patients to us. So we need to work with the medical students, with the residents, work with the primary care physicians, cardiologists, nephrologists, or anybody who's involved in their care and help them improve their knowledge base to improve the diagnosis of amyloidosis in a timely fashion. Now, once these patients are diagnosed and come to see you, it's important to work in a team approach. This is our team approach where not only the hematologists are involved in the care, we have a team of cardiologists, nephrologists, and neurologists. We collaborate and provide care to these patients. And thank you.
So we thank Dr. Faiz for a comprehensive talk. So the next talk is by Professor Saad Usmani. He is a myeloma specialist and cellular therapist at Memorial Sloan Kettering Cancer Center in New York. And he's going to talk about how I sequence treatment in multiple myeloma.
Hello, everyone. My name is Saad Usmani. I'm the chief of the myeloma service at Memorial Sloan Kettering Cancer Center. And over the next, several slides, I'm going to try to go over the management strategies for frontline newly diagnosed myeloma patients that we are adopting here at MSK. And I'm happy to answer, how this would impact, your particular area. These are my disclosures. The way that we approach newly diagnosed myeloma today is different from how I was taught to approach it when I was in my training years. At that time, we used to treat myeloma, gently wait for the symptoms, to occur before we acted, and we would treat with defined duration of treatment because we did not have good treatment options. Now, what we are trying to do is picking the strategies that give us the best likelihood of deep responses for our patients, because achieving good depth of response in that first year of diagnosis and then eventually maintaining it is very important for survival outcomes. And this is where we're finding not just achieving MRD negativity, but deeper responses and then sustain that MRD negativity is what has led to the improvement, the biggest improvement in survival outcomes for patients. And as we think to the future, we have had the schema of induction, consolidation, and maintenance for myeloma, which we had adapted, which actually Dr. Barlogi had originally adapted from the leukemia world into myeloma. But we have novel therapies that do that for us now. We're optimizing treatments that are different for different diseases, disease biologies, I should say, disease burdens, of course, and then we're paying attention more to patient characteristics and preferences with the plethora of options we have. I think it's very important to always put the best treatment strategy for your myeloma patients. And specifically for high-risk disease, we don't get many chances. So picking the right treatments early on is important. And then, do not forget supportive care measures, bone health, infection prevention. As we talk about, quality of life for our patients, I think all of those measures become very important. Our staging tools are getting better. They used to focus more on disease burden. Now we're starting to incorporate more disease biology features, whether it's karyotypic abnormalities or elevated serum LDH levels that can correlate with extramedullary disease. But if you look at that left bottom table, there are so many other high-risk features that are missing. And then, of course, we don't account for ultra high-risk disease in our staging criteria. So there's several nuances that we have to reconcile. And we are developing newer, more dynamic tools for prognostication, including this JCO paper that just came out, where we've collaborated with several other groups, to look at patient characteristics as well as disease biologies. Now, the treatment paradigm for newly diagnosed myeloma patients over the past, 12 to 15 years has followed this induction therapy schema, followed by transplantation for eligible patients and then maintenance, with the idea being you to reduce the disease burden with that initial strategy and then maintain patients and responses. And with that approach, along with supportive care measures, bone health, and infection management, we have improved the overall survival outcomes for patients. Standard risk patients specifically, the median is probably around 13 years or so, and for high risk patients around 7 years or so. And so, we have come a long way. We still have a long way to go, especially for high risk patients. And you'll hear me, say this time and again throughout my presentations. Now, let's talk about, where we've come from and where we are going. So the SWOG 777 trial was the first randomized phase 3 study that looked at combining two different mechanisms of actions, in a triplet induction therapy and comparing it to a single mechanism of action. Now, I'm not discounting steroids. They play an important role in this treatment of myeloma. But this, I guess, in another way of saying is triplet versus doublet frontline induction treatment. This trial laid the foundation for RVD being the standard of care triplet induction regimen. And we have all used it. We were actually using it even before the study was published based on the phase 1-2 data in the US. But, this kind of augmented our clinical practice. The other important question when we think about, frontline treatment approaches is, once the novel agents came about, do we keep on using them? Can we do away with autologous stem cell transplantation? And the answer was transplant is important, in terms of improving depth of response that translates into PFS benefit for patients. So the IFM 2009 trial actually demonstrated that RVD transplant was superior, to RVD alone. From that standpoint. So, very important to, appreciate, this slide here, that you give your patients the best likelihood of being, getting to MRD negativity and then staying in, good response if you pick IVD followed by transplant and then, patients went on maintenance. In the IFM 2009 study. Len maintenance was continued for about a year before being discontinued. At that time, there were concerns about the second primary malignancies, and that is what had led to that change in the schema. However, the sister study determination, which was a very similar design to the IFM 2009, and the difference was continuous maintenance. This study was slow to accrue and finally read out a year and a half ago and was eventually published. But gave us the same kind of message that the primary endpoint, which was PFS, after 70 months of follow-up, was in favor of early transplant, and time to progression, the same thing. At the 76-month median follow-up, OS had not been reached for either arm. Another way that investigators do, from the study were talk about this, that there is no OS benefit or there is no change difference in OS at this point. And that's how I would leave it, that at the current point, at the 76-month follow-up, the OS is similar. But with a median OS in a population of 12, 13 plus years, I'm not expecting to see OS differences at 5 or 6 years. So we'll see what these data look like. It looks like the SPM overall percentage was similar in the two arms, but the kind of SPMs that happened were a little bit of different. More lymphoid in the RBD alone arm, myeloid in the RBD auto arm when it comes to hematologic AEs. What is more profound to see is the PFS benefit. If you break it down by high risk versus standard risk, both groups benefit, but the high risk patients, there's certainly a profound benefit to using autologous stem cell transplantation early. So, I'm making the case that triplet induction and transplant, has to be part of the schema of eligible patients when it comes to frontline strategy. Can we improve on depth of response by adding anti-CD38 monoclonal antibody? Sure, let's explore that particular avenue with adding of daratumumab. This was evaluated in the Griffin trial. This was a proof of concept study, that was led by my previous center, the Levine Cancer Institute in P4. He's one of my faculty members, led that clinical trial. The schema was very simple, and our primary endpoint was, can we improve stringent CR rates after consolidation? So patients received dara-RBD as part of induction and then post-transplant consolidation, and then went on dara-len as maintenance. And the standard of care arm had RBD as induction, post-transplant consolidation, and then lenalidomide as maintenance. So, stringent CR was the primary endpoint, and it was already met and reported on. Here I want you to pay attention to MRD negativity rates. So whether you looked at 10 to the minus 6 or 10 to the minus 5, it was superior in the daratumumab containing arm. And, here dara was incorporated as part of, all phases of therapy. And you can see that profound impact on MRD negativity rates. And that ended up translating into PFS benefits. So you can see that at the 4-year mark, the PFS benefit was 87% in the dara arm of the Griffin trial and 70% in the RBD arm, followed by len maintenance arm. So both impressive numbers, but adding dara into the schema of treatment did benefit patients. And then the OS at 4 years, we will not see differences. I'm guessing at another, 8 or 9 years in this trial. More importantly, we just had the ASH meeting, and the Perseus trial, which is a phase 3 study with the same design as the Griffin trial. So this was powered for PFS. It was presented and then published the same day in the New England Journal of Medicine as a late breaker. And this trial essentially, showed us the same thing that Griffin showed. In fact, the 4-year PFS, the same delta, 84 versus 68%, and it was 87 versus 70% in the Griffin trial. So very similar kind of PFS benefit that was shown here, and then OS as expected. It's a little early. So So OS difference, I'm guessing in Perseus and Griffin we won't see for another 5-6 years, at the earliest. But augmenting the thought that adding daratumumab or an anti-CD38 monoclonal antibody benefits patients, in this setting. Now, what about utilizing carfilzomib as part of induction? We are familiar with the Forte trial, which was a randomized phase 2 study, asking the question whether we can use carfilzomib either with an IMiD or PI before or after transplant, or can we just use carfilzomib Lendex for 12 months and it gives us the same PFS benefit? So is MEL 200 better than 16 additional cycles of KRD was the key question here, and the answer was you can't replace transplant just yet, even with KRD. You had excellent MRD negativity rates with use of KRD, but with transplantation, the MRD negativity rates were higher. Most importantly, sustained MRD negativity was much higher in the auto transplant arm, and the PFS benefit clearly showed in the KRD followed by transplant arm, and that benefit was important for both standard risk, high risk, as well as ultra high risk or double hit kind of myelomas. Now, are there any data looking at VRD versus KRD in high risk? The answer is no. The endurance trial excluded those patients because the SWOG 1211 trial was enrolling high risk patients at the time in the US cooperative group mechanism, and they were sister trials. At MSK, we looked at our own data set of patients who had high risk disease getting VRD versus KRD, both transplant eligible as well as ineligible patients. And then, Dr. Tan, Carlene Tan from our group ended up publishing this data. I think it came out in Blood Cancer Journal last year. But, the progression-free survival for high-risk patients who got KRD appeared to be better at 5 years. And looking at the 5-year overall survival estimates, they were also higher for the KRD arm, 85% versus 63%. So very important because the follow-up period for both arms in our experience was similar as well. Now, in our practice, we do utilize carfilzomib preferentially for our high-risk patients, instead of the bortezomib-based induction regimens. Do we have any data looking at addition of anti-CD38 monoclonal antibody to carfilzomib-based therapies? Yes, we do, and let's take a look at that data. Let's start off with addition of daratumumab to KRD. There are 3 independent data sets. One, the Manhattan trial that was done at MSK, looking at 8 cycles of KRD followed by maintenance treatment. Transplant was deferred in this patient population, highly enriched for high-risk karyotypic abnormalities, including GAIN1Q. Then we have the MASTER trial, which was a single-arm study looking at DARA KRD for 4 cycles, and then there was an abbreviated MRD assessment at that point, and then another 4 cycles given, and then MRD checked to see if there is sustenance of MRD negativity before stopping treatment. Again, the only thing that I want you to pay attention to is the overall response rate and MRD negativity. And then the third data set from my previous program at Levine, where my junior colleague, Dr. Manisha Bhutani, had presented this data more recently at ASH, actually, showing high rates of MRD negativity. Again, each of these data sets were enriched for high-risk karyotypic abnormalities. And on the surface, the depth of response, when we look at CR or better, looks about the same, with these experiences, when you compare DARA KRD from the MASTER trial and the Griffin DARA RVD experience. But if you look at MRD negativity rates across these data sets by karyotypic abnormality, we find that high-risk patients have a higher incidence of MRD negativity at 10 to the minus 6 compared to the DARA RVD. So so this is an important differentiator for us as well. That if we are going to use quadruplet regimen for high-risk patients, we would prefer a carfilzomib-based regimen. And more importantly, we also had the ISKIA data that was reported at ASH. This was a plenary session, surprisingly a plenary session. This study built on the Forte trial. So this particular design added, one arm was Forte KRD transplant and then KRD for 4 cycles of consolidation. The second arm was adding isatuximab to that Forte design. And the primary endpoint was post-consolidation MRD negativity rate. So very interestingly, a Griffin-like design, but focused on MRD negativity. And this clinical trial did have about a third of patients with high-risk cytogenetic abnormalities. What we saw in this trial, again, the primary endpoint went in favor of adding anti-CD38 monoclonal antibody to KRD. So MRD negativity rates at 10 to the minus 5 and 10 to the minus 6 were higher. But more importantly, look at the right side, looking at chromosome abnormalities. So, achieving MRD negativity with a higher depth, favorable for all patients, especially for high-risk patients with karyotypic abnormalities. Even though these are low numbers, but 2 or more high-risk karyotypic abnormalities, we're seeing this difference. So telling the story that, anti-CD38 monoclonal antibodies combined with, carfilzomib-based triplets, may be, more beneficial, compared to KRD alone for high risk and ultra high risk patients. Lastly, I do want to add this little bit of information. So I had mentioned early on that the endurance trial and the SWOG 1211 trial were sister studies enrolling patients in the US at the same time. Endurance looked at VRD or KRD as induction, and then len maintenance was given. The SWOG 1211 study looked at elotuzumab VRD or VRD alone, but both arms of the trial looked at VR as maintenance, with ELO being added to the ELO arm as maintenance in addition to VR. The PFS in both the trials was identical, making the case that PI IMiD-based maintenance strategy can elevate the PFS for high-risk patients. So with all these lessons in mind, this is our current schema that we utilize at MSK. We prefer DARA KRD for our high-risk patients, DARA VRD for induction in our standard-risk patients. Standard-risk patients post-transplant get len maintenance. We do not routinely utilize consolidation post-transplantation. We only consider consolidation with induction regimen for high-risk patients who did not achieve post-transplant CR before placing them on an IMiD PI-based maintenance strategy. We do have other randomized trials that we are developing in the US cooperative group mechanism for high-risk patients. Specifically, we have the TRIUMPH study, which we are really eager to start later this year, adding cilta-cel as a post-transplant consolidation for high-risk patients who have received 4-drug induction followed by transplant, and in one of the arms, and then having the DARA-len maintenance, and then in the third arm of the study, adding telketamab for defined duration of treatment. And the idea here is getting to sustain MRD negativity and PFS benefit for our high-risk patients. For primary plasma cell leukemia study, we are developing a single-arm kind of an approach and dividing up therapy based off of presence or absence of translocation 11-14, and then having a more intensive therapy that includes bispecific antibodies, being combined for those patients. So these studies are being developed, under the Alliance Myeloma Committee, which I have the privilege of leading in the US. And another very important concept that we're trying to use for standard risk patients is post-induction randomization to autologous stem cell transplant versus a bispecific antibody combination for 4 cycles before patients go on to maintenance. So this is a non-inferiority PFS study trying to see if high-dose melphalan or an autologous stem cell transplant can be replaced with more modern novel immunotherapies. Um, what about transplant ineligible patients? We have historically extrapolated data. The two regimens that we've utilized are RBD light and DRD. Both are regimens that we utilize in our practice quite commonly. The RBD light data comes from my colleague Dr. Nupur Raje at Mass General. Interestingly, one of the most influential studies, even though it was a phase 2 trial looking at dose attenuation of RVD for older myeloma patients. I think the more contemporary trial of Dara Lendex versus Lendex called the Maya trial, which I had the privilege of co-leading with Dr. Tiri Fakun. This clinical trial um, uh, looked at PFS as the primary endpoint in an older myeloma patient population. The median age of patients was 73 years, showing superior depth of response with the daratumumab-based triplet that translated into both PFS as well as OS benefit. So older patient population, continuous therapy model, but a quite efficacious regimen. And these data were updated by my colleague, Dr. Shaji Kumar, at the EHA meeting last year.
So let's talk about the IMROS clinical trial. This was a combination of isatuximab with RVD as part of induction, followed by isatuximab with Lendex, and the standard of care arm was the SWOG 777 clinical trial. So this study was positive. Primary endpoint of the study was progression-free survival, and it was met in favor of the ISA VRD arm. At the 5-month mark, the PFS rate was 63.2% compared to 45.2%, and the median PFS had already been reached in the RVD arm, and it was a little over 54 months. So at a median follow-up of 5 years, there was statistically significant PFS benefit with a hazard ratio of 0.59. And I've mentioned before that depth of response is what ends up driving this PFS benefit. Doesn't matter if it's a transplant eligible or ineligible patient population. This is the same trend that we see here. The MRD negativity rate at 10 to the minus 5, as well as sustained MRD negativity, is better with the quadruplet regimen approach here. And we're starting to see this trend of overall survival that is emerging after 5 years, but it still remains statistically not significant, so it's immature, but certainly we can start seeing this trend emerge. The Cepheus clinical trial, a randomized phase 3 study employing sub-Q daratumumab with VRD compared to VRD in transplant ineligible or transplant deferred patients, was just presented at the International Myeloma Society meeting a few weeks ago. The primary endpoint for this trial was overall MRD negativity rate, with secondary endpoints being progression-free survival, sustained MRD negativity more than 12 months, CR or better rates, as well as overall survival. The primary endpoint of MRD negativity was met in favor of the DARA-containing quadruplet arm in this study, 60.9% compared to 39.4%. Looking at MRD negativity overall at 10 to the minus 6 was also impressive and statistically significant in favor of DVRD. So was sustained MRD negativity beyond 12 months at 48.7 versus 26.3% in the VRD arm. And this does translate into progression-free survival benefit at a median follow-up of 58.7 months. The median PFS was not reached in the DVRD arm, whereas it was 52.6 months. The 54-month PFS rate was 68.1 compared to 49.5%. Hazard ratio of 0.57, which is statistically significant. Therefore, both of these trials have read out demonstrating quads are better than triplets, especially for the fit and intermediate fit patients. And this is going to inform and change our practice for this patient population.
Schema even for older patients, where for fit or intermediate fit patients, we have a data RVD light kind of an approach. And for our older frail patients, we have just DRD, which is dose attenuated. So, I know this is a lot of data and I've probably gone a little bit over time. But, to conclude, I think for newly diagnosed patients, it's very important to pick the right strategies that give us the best likelihood of depth of response in that first year of diagnosis. Anti-C38s, the quadruplets have become, a standard of care approach for patients. I think the future strategies, how do we incorporate bispecifics or CAR-Ts, as well as some biomarker-directed small molecules like venetoclax, as I mentioned, for plasma cell leukemia patients, would be very important. It's always important never to undertreat high-risk disease. So, I think that's a very, very important message that I want to give. Thank you so much for your kind attention, and a big shout out to the MSK myeloma team. I'm taking this phrase from Dr. Ken Anderson, who talks about the United Nations of myeloma, all of us working towards the cure together. And this is well represented in my team here at MSK. Thank you so much.
Thank you very much, Dr. Saad. So we've actually gone over time, but it's coffee break, so I think we can continue and have a few questions. Do we have anyone? I think we have Dr. Faiz online and also Dr. Zeba, and we have the panelists who are live here with us. So any questions here?
Yeah, which is 5 years down the line or something. Do you think that in our situation, we should follow a quadruplet regimen versus just doing RVD alone until the overall survival advantage is proven in our marginalized patients? And the third question is for Waqar, of how he does his myeloma sequencing in our part of the world, the resource-constrained world. So these are the three questions. Is myeloma curable?
Well,
at this day and age with...
Yeah, thank you so much. So I think the hope is myeloma curable? It has real promise. When I graduated from my medical school, the average survival for those patients was barely about 2 to 3 years. And now I speak with my patient in my clinic and I tell them your average survival is now approaching 8 to 10 years and it's improving every year. And now we're talking about progression-free survival of 5 to 6 years with the 4-drug induction, transplant, and maintenance therapies. And this is such an exciting time now that we are going to improve on the maintenance therapy. We are adding bispecific, we just activated our trial with elranatamab versus Revlimid. We activated our trial with iberdomide versus Revlimid. And this is the time when we are learning more and using more about the MRD directed. So I think clearly I can tell today a functional cure is possible. An actual cure is possible. I think so, but that's where we have to work together as a team. Now, question is, in a resource restraint environment, can we not use the data and just use the VRD and approach could be more of a sequential therapy? I think that's where we have to look at what's available. It is a standard to use now 4-drug induction, offer transplant or transplant eligible patient, and a post-transplant, a maintenance therapy till progression is a standard of care. Now, there are many places around the globe where they may not have access to, for whatever reasons, to all these resources. And that's where you have to have a discussion individually with the patient and family and make that decision.
Dr. Faiz, the question was that overall survival has not been shown as yet. So,
Yeah.
If it has not been shown at 5 years' time, should we start using it in the real world, or should we wait till the overall survival advantage is there or not? That is basically my question, because even if it's not resource constrained, I mean, when I talk to my patients, should I tell them that yes, 10 years down the line, we may have an overall survival advantage or no? Because right now, just a progression-free.
Right. If we look at the historical data coming from the first trial, SWAG, the 777 study, and then over the years, if you look at the survival advantages and divide your time into 3 or 5 year interval, every 3 to 5 years, we have seen improvement in the overall survival. We just need more longer data to show the 4-drug induction therapy will also impact positively the overall survival. So I am a believer that this MRD negativity and a longer progression-free survival, these are the earlier signs of overall survival, because we have seen that this is true in the last 20 years. So it's going to be true in the next decade and after that as well.
Okay. Dr. Bakar, a question to you. How are you practicing myeloma for us here in a resource-constrained environment? How do you sequence us? We've heard all these very good talks, excellent talks of what is available. You are working in a premier institute, and I would like to know how you're practicing.
So, Dr. Zeba, our practice is probably around 15, 20 years back. So we're still treating upfront with either a triplet, including Velcade and Revlimid, or if they cannot afford it, then it's Cyborg. We try and take all the patients through an autologous transplant, and then we follow it up with maintenance. Now, if they have got sort of high risk sort of RISS, we go with the Velcade based maintenance if we can. Otherwise, everyone goes on to have lenalidomide based maintenance. So far, most of the patients are not able to afford any CD38 antibody, and we have zero access to any BCMA targeted therapy. So, you know, straight away your BCMA bites, your BCMA antibodies are out, and there is no CAR T cell as well. So I think our practice is still 15, 20 years back in time, where, you know, the best possible we can do is with triplet, auto, maintenance, and hope for the best.
Saad, I would like to ask you a question also, the same I asked Dr. Faiz, and I want your answer also, since you're working in a very premier institute. Do you think we can talk to our patients and say myeloma is curable? Not 10 years down the line or whatever, that lifespan has increased. Is it curable? Like we say, okay, this disease, Hodgkin's, is curable. There's a potential for cure with lymphoma. What about myeloma?
So Zeba, first of all, thank you for the colleagues for orchestrating this meeting, and I think your question is very pertinent. So I'm actually at the International Myeloma Working Group response criteria meeting in Paris, where we are actually having this discussion on can we define curability in myeloma, and many of us here believe that at least for 10% of patients with the quadruplet induction transplant with 2-drug maintenance treatment, we are getting there. We can get sustained MRD negativity for 5+ years, and we're contemplating whether that needs to be one of the secondary endpoints for future trials. So yes, I mean that we do believe that we can get excellent disease control for patients, especially now that we have immunotherapies coming. I also appreciate the comment made by Dr. Waqas, Waqar as well, that in Pakistan, even with the triplet induction therapy, with or without transplant, and with len maintenance, I think that may be the best that one can potentially do. But even with that approach, when we look at the Canadian data sets, the standard risk patients have an overall survival of about 13 years. High-risk patients still about 5 odd years. But that tells you that even if you get 3-drug induction for patients, with or without an auto, and then put them on continuous maintenance treatment, most standard risk patients will do well. So sorry about the long answer, but I just wanted to kind of also mention how you guys are managing patients and how you're trying to optimize it under the circumstances.
Can I just squeeze in a quick question? Actually, it's a patient. I had a 48-year-old patient who was diagnosed as a solitary plasmacytoma in 2019. He was on maintenance. He was on surveillance, and he relapsed again with the plasmacytoma in 2021. He's a 48-year-old man. Now, he came to my clinic around a month back. All the workup for myeloma was negative, but his PET-CT showed multiple lytic lesions in the body. And he was having pain in those lesion sites as well, So my question is, should we treat this patient as a myeloma patient? And if the answer is yes, what would be your preferred regimen,
So may I ask you the question, when you say all the workup for myeloma was negative, what do you mean by that?
Okay, so urine immunofixation, ASPEP, serum immunofixation, bone marrow biopsy, nothing, the electrolytes here.
So do you have any evidence of malignant plasma cells on any biopsy?
The previous ones, we have two biopsies, which were both positive for the plasmacytoma, Right now, we do not have a biopsy, but the previous biopsies too, both of them were positive for plasmacytoma.
Okay, so this is your macrofocal multiple myeloma that's not secreting protein. Okay. And one should approach this as active myeloma. So this is a young patient, should get induction treatment, should have transplant considerations if possible, if feasible, if financially or logistically. And I would welcome Faiz Bhai's comments as well.
I agree. I just want to know, at the time of initial presentation, did this patient have any paraprotein? Was that also non-secretory, or this is the first time he's presenting with the non-secretory?
The workup throughout the 4 years has been negative, It's been worked up 2-3 times, by different institutions, and all of them was negative. Now, he came to me and started him on a triplet, but he was asking me that with the amount of disease I have, should DARA be added to the mix, That is what he asked me. So, in Pakistan, if I use DARA right now, so what will be if I use DARA right now, should I go for the transplant or what?
Dr. Faiz.
So, we talked about this, we have to look at the ground realities. Standard remains standard. We saw wonderful presentation by Dr. Usmani that there's a significant benefit for younger patients, standard risk patient for myeloma with 4-drug induction, transplant followed by maintenance therapy. So that remains the current standard. Now you have to individualize recommendations based on this. So if these patients come to my clinic in Ohio, yes, I will give him 4-drug induction and then the consolidation of the high-dose melphalan followed by maintenance therapy.
So you are all up for DARA, right? That's what you're saying?
Right.
Okay, thank you very much.
Thank you. Dr. Bushra.
It's Dr. Bushra Ehsan here. I have a quick question for both of you. It's regarding amyloidosis. So when there is a clear-cut amyloidosis that you have an organ involvement and you get a kidney biopsy and it's involved, and you have a serum protein electrophoresis with the monoclonal band or a serum-free light chains depicting the same, then yes, we can offer treatment and auto-transplant. But once in a while, we get patients referred from nephrologists for workup for chronic kidney disease, and they do a biopsy, renal biopsy, and it's amyloid stained. But we do not have any paraprotein, or we have equivocal light chains, and in the marrow there is 5 to 10% polyclonal plasma cells. We do not have SAPS scanning here. We do not have proteomic sequencing to tell whether it's AL or AA amyloid. So as we know, early on diagnosis is more important here. When it's later, then the prognosis is bad. So what should we do in such circumstances? We cannot offer them chemo with just this amyloid in the kidney. What's your approach to that?
So the involved organ biopsy is the gold standard, and if for whatever reason you cannot get an answer from the involved organ, surrogate organ biopsy is the second best option. Though the yield, even in our hand, is low, at best maybe around 70% or so, but it's easy. Skin biopsy, a GI biopsy, colorectal biopsy can be done. And then immunofixation. If you don't have access to electron microscopy or mass spectrometry, and there's a clone and there's a electron immunofixation on the kidney biopsy is positive, so you have to put the evidence together. At the same time, you can also look at other organs. An echocardiogram and EKG can give you some guidance about other organ involvement.
And to add to those comments, I completely agree. I think that the other important point to make is amyloidosis is a low plasma cell burden disease. So you can have a very tiny clone in the bone marrow that's producing small amounts of clonogenic protein that can cause fibril formation and organ damage. So confirming this with, as Dr. Anwer mentioned, with additional sources of biopsy before intervening. And for these kind of patients, if you're seeing worsening of organ damage, a short trial of treatment can give you the indication whether there will be an improvement in that end organ damage. So renal function is typically, if you catch it early, it's reasonably reversible. So when in doubt, a brief trial may actually be the easiest clinical intervention to do without, I'm trying to just make sure that we pay attention to the constraints that you may have in your practice in Pakistan.
Thank you. Saad, the question continuing with Bushra's question is there a role of surgery if there is a very localized kidney involvement with amyloid and there is no disease elsewhere, anywhere, where, as Bushra has mentioned, if you work it up and there's nothing there, you're giving a trial of chemotherapy or whatever, but is there a role of surgery I'm not sure if there's one, but this is just a question.
Yeah,
if
typically
there's no
not.
disease
Yeah.
anywhere.
Typically not. I think, for those patients, we might, just observe and see if the natural history changes over time as well. That's another potential option, depending on the degree of renal insufficiency. Faiz bhai, what do you think?
Yeah, this kidney biopsy proven amyloidosis is a systemic process. Similarly, heart, skin biopsy, if you see blood vasculature involvement in the bone marrow biopsy, this is all systemic amyloidosis, no role for surgery. Now, we recently published a case series of more than 110 cases of localized amyloidosis, light chain localized amyloidosis. A lung nodule, somewhere a nodule in the upper digestive tract, somewhere a nodule in the urinary tract, you do a biopsy, but there's no systemic involvement. Clearly, there's a role of localized surgery in that setting, but a kidney biopsy is always a systemic involvement.
Thank you very much. Any other questions, or do you have a question? Yeah, just one final question, and then I think we'll be done for this session.
I have a question related to anti-CD38 therapy. How will you evaluate MRD on flow cytometry?
So, Dr. Saad, how will you evaluate MRD after CD38 therapy?
Yeah, so typically when we look at the flow cytometry, we're looking at CD138, not CD38. As one of the markers on flow cytometry. If you look at the Euroflow for MRD by flow, it accounts for that because CD38 positivity can be seen with regulatory B cells, T cells, so it is a little bit more diffuse. CD138 is more specific.
Thank you very much. So that brings this session to an end. I thank all the panelists and the speakers. Thank you so much.